All right, so while I sort the slides out, I'll introduce myself for those who don't already know me. So my name is Bleddyn Rees. I'm the Deputy Chair of the ECH Alliance and the Chair of the Digital Health Society. And you'll find out a little bit more about those as we go through the next session. So what's important about this is I'm going to do the quick introduction to the topic. So the DHS, the Digital Health Society, is the data and digital arm of the ECH Alliance. Few new technologies have developed with such speed or engendered such contrasting emotions of anxiety and fear and hope and excitement as AI. Whilst we understand the concerns in other sectors, healthcare has been an early adopter of AI and the opportunities for new drugs, new products, services, treatments, and better patient outcomes with the help of AI are real and substantial. Today, we seek to have a balanced conversation over the next hour and a half about AI in healthcare. There has been a range of governance and regulatory initiatives, including the US Executive Order on AI Standards for Safety and Security, the G7 Code of Conduct, the passing of the European AI Act, and creating an environment of trust and acceptances that maximize the benefits of AI, to name but a few. Perhaps there's too many initiatives, too many documents that have been published. So the Digital Health Society convened two groups of stakeholders, experts, including academics, policymakers, regulators, industry, health systems, and patient groups. In 2020, we started a roundtable program on the European, to help the European Commission design the European Health Data Space. And on the agendas that are on your chairs, you'll see there's a link to a QR code with the 6 published reports. But to bring this introduction to an end, I want to refer to the UN, who in September 2023 published an interim report governing AI for humanity and setting out 5 principles. So I'm just going to quickly run through what those were. So principle 1 was AI should be governed exclusively by and for the benefit of all. 2, AI must be governed in the public interest. 3, AI governance should be built in step with data governance and the promotion of data commons. 4, AI governance must be universal, networked, and rooted in adaptive multi-stakeholder collaboration. 5, AI governance should be anchored in the UN Charter, international human rights law, and other agreed international commitments such as the Sustainable Development Goals. So that's the background to the conversations that are going to take place. And the format, okay, there are 2 short keynote presentations that will give you some perspective from the ITU and the UN. And also then, we're going to talk and have 2 panels of 35 minutes that will address some of the issues. And I don't intend to closely moderate either of the panels. There are some very capable people on these panels, and I'm going to let the conversation develop between them. If there are really pressing questions, I'm going to trust you as adults to put your hands up, and let's see how that goes. But anybody who asks a question, I have a couple of rules, okay? I don't want an announcement or a statement about it. I just want a short question that allows discussion, because if, like this morning, there are many of you who want to ask questions, there'll be too little time to have long statements and long questions. So I'm not trying to be rude, I'm just trying to give the room, the maximum number of people, the opportunity to participate. Okay, so that is the panel today, and you've got on, as I said, on the leaflets, you can see all of the names. So I'm not going to spend much longer other than saying a little bit about the ECH Alliance. So turning to what do we do? So we connect, convene, amplify, and accelerate organizations involved in the delivery of health and social care. So those of you who were here this morning will have started to see us actually in practice make connections between speakers, between organizations, and facilitate a collaboration across borders and truly globally. So 14 years ago, we came up with the concept of building communities of all stakeholders needed to transform health and care that were geographically based. In a way that pharma's global, medtech's global, tech is global, healthcare is at best national, often regional, which explains the inefficiency in cost terms, explains the variation in quality, and the poor performance in outcomes in comparison within borders. So our idea was to take best practice, lessons learned, failure from one place to another overnight. Really simple thing to say, much more difficult to deliver. It's about building trust and relationships between all of these stakeholders. So we also have thematic innovation ecosystems, which are all about topic-specific discussions, which are virtual. And these started to emerge as a result of COVID when none of our ecosystems could meet. So we started with 4, never sure whether this would work. We thought naively we were breaking down barriers between public, private, and voluntary. And then when we created the network, we suddenly found that today we have over 80 of these communities around the world. There is no other organization anywhere in the world who is doing what we do. But what we need is all of the members to participate, to collaborate, and to actually share best practice, lessons learned, and failure. So that's enough about me. And now I will hand over to Bernardo, who's going to give you the first keynote. So thank you.
Thank you. Good afternoon. It is my pleasure to be here with you today. My name is Bernardo Mariana. I'm the Assistant Secretary General, Chief Information Technology Officer at United Nations Secretariat. And being networked, connected, bringing everyone together, it is key for us to develop, sustain, and achieve the SDG, the Sustainable Development. I believe science and technology is not just an opportunity. It is a necessity to achieve those SDGs. It is a necessity to achieve a change that is sustainable. I'm sure and I hope you all realize that we are in this crossroad where old rules are still there and we believe in them, but those old rules are not necessarily working in this new ecosystem where driven by AI, transformed by AI, let alone in this digital ecosystem. And those old rules, if they're not up to date with the fast transformation of artificial intelligence, we will not deliver, it will not leave a legacy, will not deliver the benefit of this technology, and will not leave a legacy that we can all be proud of one day when the next generations look back and think about the decisions we took today. So think about that future generation and what we are doing today to make sure that the world is a better place, AI is used for good, and AI transforms lives, but also protects what needs to be protected, human rights and all the other elements included in the United Nations Charter. As a Chief Information Technology Officer at the United Nations, my responsibility is to lead the organization's transformational drive to ensure that technology is used for good, but also to ensure AI is delivered to ensure that that transformation, that acceleration, that business value that we want to extract out of technology is extracted in a responsible, is extracted in a fast way, is and deliver those impacts that we need to deliver. I'm an electrical engineer by training, and I have a profound appreciation to science and as well technology and innovation. But let's also not forget that the same way we benefited from science technology during the previous industrial revolutions, we also were perhaps blind in some of the areas in the impact that we only saw later on. So let's learn from that, and let's do better this time. I can give one example. In the Industrial Revolution, when we didn't think about carbon emission. I can give you another example of the race to space. We are not thinking about debris in the space. And NASA say there are over 20,000 big objects floating around the world. So let's think not just on what we can deliver fast, but how can we come together, making sure that both those who are good at research to understand the impact, those that are good at execution to make sure that we extract the benefit, those that are good at establishing rules of governance, we bring the best out of each one of us to make sure that the AI delivers on its promise, protects the humanity, and accelerates that achievement of sustainable development goals. I said we are in this crossroad of change. I ask you, just Google what were the top 10 richest companies in 2020. And Google again, the top 10 richest company in 2023. The difference in percentage of the tech companies that were in that top 10 in 2020 and now will show you that technology, it is driving the transformation big way. It was 30%, 40% max, the top 10 in 2020, in 2000. Now it's around 70%. The big oil companies, the big logistical companies that used to be in that top 10, they are no longer there. So the big tech companies are there. So all to say that if we want to drive that change, extract the positive and benefits of technology, we need to bring everyone in that conversation. We need to ensure that it's not just about governments talking, it's not just about academia talking, it's not about just the civil society talking. It is all of us plus the private sector, those big tech. And the other transformation that I wanted to also mention that I hope you realize is that data is the new gold. That gold rush that we had many centuries ago, you have now, but the gold is replaced with data. Those who have data, those who can mine on data, those who can train their AI models, they are the ones leading the way. They are the ones extracting the profit. They are the ones making all of you the consumers of the product. They are the ones reaping all the benefits. So data, it is the new gold today in that digital ecosystem. So therefore, it is important that as we talk about AI, we also talk about data. We don't want the model to be biased. We don't want the model to deliver inaccurate information. But also, we need to think, because we always tend to think that inaccuracy or hallucination of AI comes because of the error of the model or the programming of that engineer or the programmer that designed that model. but sometimes it can be also injected deliberately to deliberately deliver that wrong result, to deliberately make a point on something that somebody wants to influence the masses. So this combination of data, computing power, and the power of and the algorithms and requires us to also think about capacity. The capacity of the health workers to make sure that they can leverage on technology, the capacity of all the sectors that work and leverage on AI, the change of professions where AI can deliver and augment this human capacity, and making sure, as the Secretary General said, humans are always in charge. It's not the result of the algorithm that will decide on anything that you extract from there. So all to say that as we bring this topic, as we discuss AI for health, let's ensure that this regulatory framework is not something that is just decided by governments. It's decided together with the private sector, academia, and as well as civil society to make sure that this inclusivity brings everyone together. Also, let's not forget there are 2.6 billion people that still not connected. So we want not leave anyone behind. It's one of the SDG goals, right? So in concluding, and I want to remind that the Summit of the Future and the Pact of the Future that was just signed or endorsed by member states after very, very, very difficult negotiations, I can tell you. At some point, I was crossing my fingers that, okay, I hope it passed. And thank God it passed. It is an opportunity for us to leverage on that, both the report from the Secretary General AI Advisory Board, as well as the Pact of the Future, and governing AI for humanity. Those are the principles that I hope that we can all embrace and take forward and make them, operationalize them, bringing them into governance, bringing them into regulation, and make sure that it benefits everyone. So let's continue to work together in that new model of partnership. And I have to say, being in the United Nations 30 years, it's not easy to bring the private sector in the same table and talk about partnership, because the traditional engagement is client, is customer, is on the sales part, right? So I'm buying something from the private sector, but we have no choice. As much difficult as it is to have that conversation, at least I always say that in the United Nations, we are so used to have countries in different extremes over many topics. In the case of discussions and conversations, bringing the private sector partnership together with the civil society and academia on the same table, taking those extreme positions of different groups together, this is what the United Nations is good for. We are good at that. And we want to make sure that forums like this forum of ECH Alliance is a forum that create the culture of that joint partnership, multiple stakeholders of all sorts, to make sure that we get used to hear each other, understand each other's language, and making sure that we can all chart the journey for a better future and a better legacy for us and for the generations to come. So I wish you a great engagement, great discussions. Most important, great actions that follow the discussions to make sure that the results, and next time we meet, we can all celebrate of progress, results that came from those discussions of today. Thank you.
Speaker has not arrived, so I'm going to use some discretion and say, does anyone have a question for Bernardo? This is your opportunity to speak to and ask a question to the Assistant Secretary General. No? Oh, we've got them silent. Okay.
I should have spoken in Portuguese. You would understand. Good.
So thank you very much. Okay, so if I can ask the first panel to come up and take their seats. So for those of you, that's Ayn, Irene, Rachel, and Raj. So sit anywhere, doesn't matter. So just a little bit of explanation about what we're about to do. So each speaker or each panelist is going to have 2 minutes to make a statement about this particular topic. And when we finish that, I'm just going to let them embark on a discussion between themselves around what's important. And in particular, okay, this panel is going to be talking about data access, standardization, diagnostics and treatment, ethical considerations and bias, data first, AI later, and international collaboration and the future of AI. So they ought to finish that in about 5 minutes, I think, and solve all the problems. So right, Irene, do you want to go first? No? Okay, well, Rachel, we'll start the other end. Okay, Rachel, fire away.
You all right with that, Irene?
Yeah, I didn't know it was that easy.
Okay. So for my sins, I've been a CIO looking after a city region and set of healthcare organizations, which was deploying AI back in 2016, 2017. And I have many scars. And for me, AI is like an iceberg. Yeah. We see all of the real possibility just above the surface. It looks really beautiful. But underneath it is a massive iceberg of things that we need to do. And those things include getting clean, codified, real-time, good data. Our data, frankly, in many health systems is feral. It's wild. It's inconsistent, and it's locked away in many cases. Secondly, we need really good governance and lifecycle management of AI. We need systems that will oversight the performance. We need to really regard this as a junior doctor or nurse, if you like. We would appraise it, we would supervise it. We would do all of those, sort of things to make sure that it's safe. And we also need to make sure we've got the skills. So I used to also, while I was a CIO, be the CEO of the NHS Digital Academy, bringing through in the UK all of the skills that we need so that doctors, nurses, and senior leaders could understand AI. Because frankly, if we do leverage AI fully in the future, it's going to change the target operating model of health and care, right? So for me, looking underneath the iceberg is the bit that we need to do, because unless we get the foundations right, we are not going to do the right thing with AI. If we rush ahead, we will have a hype curve with a real hangover at the end of it. And so for me, the phrase more haste, less speed, we need to stop, think, and prepare. AI has huge possibilities. But as a result of that, I've joined OpenAIRE part-time, to be CEO, working with the other standards bodies so that we can get our data ready for AI and not have that sort of crash of the hype curve, putting potentially people's, treatment or, lives at risk. So for me, please do think about the iceberg.
Thank you. Well, I think the genie is out of the box. And I can't see putting it back there. But also I think that predictive modeling was there long before ChatGPT. So that, in addition to fear of any new technologies, I think that if we look at it as I'm trained as a medical doctor, any doctor would look at it is, I would use anything in my hand to help the patients. And if I cannot use the information, then I'd like to find ways, what are the tools that help me to make use of that information in such a way that the problems can be solved. So that I believe that, yes, as we heard just recently, confirmation from the UN, data is the new gold. I'm happy to say that, well, I felt something like that already in 1996 in the third year medical grade when I started my own journey into what is now really data-based public health. And we started collecting data from health insurance they were, at that time, they had their own silos put together and calculate the cost of schizophrenia and to understand at the system level from the numbers what can we do better. And I will finish up with the idea that when the fear of AI very often comes from the idea that, oh, now the robots will make, clinical decisions and decide on behalf of doctors. I don't think that will be the case, but until we get even there, when they're really frontline, chatbots talking to the patients, there is 40% of administrative burden that currently medical professionals spend their time. That is 25% of the total healthcare costs, which is $1 trillion in this country. So if we can even reduce a fraction of that with the help of AI, and then carefully learn all the risks that we will be there and that we'll need to learn to mitigate in the frontline healthcare provision, we have already served the mankind a favor, because all the healthcare systems around the globe are under huge pressure on financial sustainability, and our doctors and nurses are stressed out and burned out, so that yes, there is an opportunity and low-hanging fruits with at least manageable risks. And I'm happy that you have all convened here with the belief that it is possible.
Great, thank you. And just for the rest of the audience to understand where Ein comes from, he's from Estonia. And for those of you who don't know much about Europe, Estonia has something called the X-Road, which is the digital platform for all public services. So it is the exemplar system in Europe. So Ein's got a lot of practical knowledge and experience of using health data in a system.
Tiny comment, and anyone who has heard that GDPR prevents people from using data, that's not true. I was part of the member of the Estonian delegation negotiating that for the use of healthcare. It can be done. It helps to govern the data, but having good rules in place does not prevent you from doing good things in healthcare with the data from the practice in Estonia.
Thank you. Raj.
Thank you. From Estonia, we moved to India, where all the big tech company CEOs are from India. So having said that, I was also told by Bledin that, you won't get beaten for speaking anything. So I'm taking that we have a very decent panel, will not argue, respectfully disagree. But when I look at a lot of hype and hope on AI, I get concerned. I think my friend Bernardo has set the stage by giving all the aspects of AI, but I'm coming back to the basics. Data. Data has three issues. I call them 3 I's of data. Integrity of data, that's a big question mark. Integration of data, you don't talk to each other as systems. And the last one is intelligence, which we talk most often is intelligence. So based on what we saw as challenges, and we have done extensive research before I launched the campaign, Data First, AI Later, in Geneva on 30th May, is trying to bring the spotlight on data first. If the data is not great, AI is not going to be great. Having said that, that's one part that I lead as a campaign to bring clean data that's interoperable, to start putting intelligence on that. And the second thing I think we shouldn't brush this point under the carpet is AI for jobs. I'm just coming from the committee I chair in Commonwealth called the Commonwealth AI Consortium for Capacity Building. It will take away jobs. It will create jobs also, but that depends on how much capacity we have built for it, how many people we have trained for it. So I think one of the things that I'm also looking at driving is AI for jobs. Whether it's healthcare or any sector, I think we can create jobs using AI. So for me, I have 2 very diverse discussion points: integrity, integration, and jobs. Thank you.
Thank you. So I think the genie is out of the bottle, but different shades of that genie. So I'll come back to the transparency point at the end in terms of my call to action, which I thought we were all asked to do. So I've done my homework. So I'm Kate Newhouse. I'm Chief Operating Officer and Board Director at a private provider called Kooth. So I'm bringing the private sector lens here. And I want to deliver the view of an at-scale provider, a digital provider across borders. So we operate across the UK and across the US. So what do we do? Well, we've spent about the last 20 years trying to build mentally healthier populations. Can everyone hear me okay? Yeah? And we are trying to support everyone at that first point of need. And so in terms of our approach to ethical AI and what we are going to do with it, I thought it'd be helpful just to say a practical few words of how we are approaching it. And I think it's important to think through the application of AI, both at an individual, a community, and a system level. And that's kind of the lens through which we look at it here at Kooth. So looking at the potential of how it can enhance effective digital mental health care. So we look at it from a user perspective. How can we enhance care to make it more accessible, more personalized, and more responsive? How can it be more tailored to that individual with using the power of data connectivity to understand that and then act on it? How can we augment our practitioners' service delivery capability? So those practitioners that we have supporting our users, how can we augment them so that we can prioritize and safeguard that really important human connection that we know is so core and cannot be lost from true healthcare delivery? And then if we look at it from a system level, how do we use that power of data connectivity to activate healthcare systems, to use AI to present real-time data so that we can be more responsive, more accurate in using the resources that we have to better meet the need of the populations that we have at large? We can be much more specific, much more timely, and much less wasteful by delivering that. So my call to action, so being a provider is ever practical, is we look at this often from a top-down perspective, from a kind of regulation top-down. And so coming back to this transparency point, what about a transparency pledge where all organizations, whether they are government, membership organizations, private, public, charity, third sector, commit to publishing their approach to AI? In so doing, we then create that public accountability and that expert demanded accountability for how we move forward with this together.
Fantastic. Thank you very much. Irene.
Good morning, afternoon. It's a full day. My name is Irene Aninye. I'm the Chief Science Officer for the Society for Women's Health Research. And every point here is just, it's been very salient. And, you know, AI, as you mentioned, it's this data connection and data integration, but I would almost challenge you to think, where does the data come from? Women have historically been underrepresented in medical research, and this data is missing for this large population of our world. And so while AI can take it to the next level, we almost have to step back and figure out the data that we're amplifying and the data that we're using to drive this change and this innovation. If it's missing these critical data points, that there's a whole demographic that's missing. We see this without the AI, for example, in interventions for cardiovascular disease for women. A lot of the data was based heavily on male data and men in these studies. So when we develop interventions, they don't play out the same for women. And so that's something that I think we also have to think about, how far back. It's not going to be easy, but we almost have to ensure that as moving forward, we have a good foundation of the data that we're using to generate and to be the foundation for the AI advancements.
Okay, so let's develop this data first, AI later, and which a number of you talked about. So Irene, you've just made it very clear about missing data and that the data sets are incomplete. Rachel, can you start us off on synthetic data and whether AI using synthetic data is part of a possible workaround whilst we improve the quality of the data?
Yes, and that's a really interesting point. And I'm part of some research that's actually taking part in Berlin at the moment with a professor there to look at the performance of AI over various types of data, you know, unstructured data, clean codified data, you know, synthetic data. And many of our populations are not fully represented in the data sets we have today. For instance, I know from, you know, the areas that I'd worked, we had plenty of data, you know, for people, who were white or had come from our Pakistani communities. But as we got down to some of the other groups, we didn't have great data for those groups at all. And the way that we had to look at this was to actually create synthetic data. And that was to take populations from other places. That was to take, demographics that we knew happened in a population and synthesize a population for training, and then validate it against a population that we had. And I think the question really is, we don't have that much published research on it now, but it is a first step towards building enough data to actually get to a point where you can validate an algorithm. But you have to put a lot of thought into your population, who they are, and what is indeed missing. Are you missing data on women? Are you missing data on a certain age demographic? Are you missing data on people with a certain condition? And the preparation of data for your training of algorithms needs a huge amount of thought. Also, as you move to another borough, where you might be, I've worked in one borough with, very distinct demographics, very different demographics in another one. Synthetic data, which is from their data set, can allow you to test and see whether the algorithm has got any, unwarranted effects. And so synthetic data is becoming something that can really help us. And it also helps with GDPR, because certainly in the NHS, where, we didn't want to hand over data to an AI provider for training or a university for training or whatever else, we could synthesize the population with the same statistical demographics, but no real humans in it. So it really helped us to train. So synthetic data is definitely part of the toolkit that we need, and it can definitely help us to get further faster. But I'm hoping actually that we have to lean on it less as we get much better in terms of actually ensuring that we have the right underlying data.
So Raj, can you pick up your concerns about the quality of data, and so expand on why data first, AI later?
Thanks, Glenn. I think I'll go more fundamental on the origins of data. I think you raised this point very clearly. So, and Bernardo highlighted that number, which I love, is 2.6 billion people are still not connected to the internet. We're leaving out a huge number of people out of the net. So the first thing I think where we see the role of multilateral bodies coming in, because the governments which are member state driven, UN is member state driven, WHO is member state driven, is first we need to get out with the roadmap of data. Like we have the birth and death registry system, you got to start with the basics of that. Then if you start looking at the screenings data, you have to build the layers on that. It's going to be a long walk before you start talking about AI. But I think first start with the birth and death registry system, which I think every country should adopt if they have not yet. And then start building on the screenings data. I think we have got, then we will get later into the DNA, genomics, and whole lot of things. But I think first we need to get roadmap of data to start the integrity of data first. If that's missing, some data from here, some data from here, you know what kind of dish you're going to cook. So I think data is very exciting, but the basics are still not clear. We need to get that clarity to talk about data and AI later.
Anybody want to disagree?
I'd like to add something, actually. So concepts in healthcare data are stored in thousands of different ways. I did an audit recently of your vital signs, your observations in one university hospital, 47 different ways of recording it without the data fields matching. So I'd just like to back what Raj is saying. Absolutely, but we need to get down to the granular level of systems and how we record this data, because it's completely inconsistent at the moment.
Can I?
Just add to what Rachel is saying, that every one of us here in this room is a subject of research, because all of our mobile phones have our basic health data. We don't know about it. But just imagine if all this was coherently used for population health, what kind of things we could have done for communities. It's just about getting the heads right on the usability of data. And once populations see it, if you can tell a community or particular community that you are more susceptible to obesity and metabolic disorders, they will see value of data. They will say, I'm willing to share more. But I think we have not been able to showcase the value of data to populations. That we got to do.
I think that's what I was going to say, is that you have to start with some key lines of inquiry. If you just look to get the whole data picture mapped, you'll never get there. So whilst I totally and utterly understand and agree with the fact that we have big holes of representation and in terms of an inclusive approach to that data, if we don't start with what are the key things that we are trying to solve in a kind of sandpit way, rather than try and map everything from the ground up, we just won't get there. And talking about your iceberg, we need to have some really good news stories of what you can deliver to do this, to help this movement go forward in a positive way.
Well, I wanted to disagree with you and then agree and then disagree again and now agree. But basically what Kate said resonates with me as well. So I don't think that we should put aside the AI until we get all the data sorted out. And that's what Raju said yourself, that actually there is data already, in all of our mobile phones. And at the same time, this is the thing that we discovered when in our clinic 2 years ago, started to think what can we do to prevent in a personalized manner mental health problems, so that we, on a mental well-being arena. And then we discovered that, yeah, there isn't such data, longitudinal data with enough data points, and actually being able to know what happens with people in between those sessions when they don't see their psychologist, or even before they reach to the psychologist. So yes, we should start collecting that data in order for that to be used then also with the proper analytical tools. And if AI, you don't like AI, let's do it with predictive modeling. That's fine with me, at least. And in that case, it is possible to start off already today. And with the quality, well, in healthcare, all the electronic medical records originally were for accounting purposes. Then later on, you needed to add also a little bit clinical information, because otherwise the health insurance wouldn't pay for you, because you needed to have at least the diagnosis there. Today, the best solutions say, okay, we need these care pathways, and UX is important, that the doctors and nurses and patients are engaged in all of that. And only then started talking about the data. So I think that the fourth generation of information systems will start actually from the data with the AI tools in mind, and then, yes, together, carefully weighing all the risks, it is still possible to do AI today with in some cases, okay, the clinical trials need to prove that it serves its purpose and all the risks are mitigated.
Wow, okay. So you are definitely talking about the right stuff, because I think we've got 6 online questions already. So we're hitting some points. A couple of things I'm going to just say. The danger with the conversation that we're having, I guess, for some people is we're sort of talking about primary use, secondary use, and there's all consumer use. And we're sort of, and some of the issues are different depending on which view you're looking at, okay? But so I'm going to start with one of the first questions we got, which was, what parameters should we use to rate the risk of AI tools in healthcare to determine what level of governance is required to ensure safety while supporting innovation?
Very short answer. A month ago, New England Journal of Medicine published a wonderful paper from the Clalit health system in Israel. And they have a very nice and very pragmatic way how to assess in 7 steps with, I believe, 70 or so checklists. Starts with the clinician telling, okay, is there a problem that we are after to solve? Then the data scientist will tell, is there a data which is available? Then the clinicians will validate again. Then you will have your DevOps engineer who tells what the infrastructure and everything. So that, yes, there are already good examples. And this was derived, to my best understanding, from the experience of actually implementing AI in a clinical setting, again, long before LLMs.
So if I can add, there's one interesting thing. There cannot be one answer for this question. So if you look at the scans from radiology, you have more ups than downs in using AI. If you look at conversational AI in low resource settings, you certainly have more upside than downside, because on one side you have no healthcare professionals. I mean, people would die for basic primary care. AI could solve that. If you look at second opinion, maybe then you got to think. So I think there can be no one answer for AI use case. Some case it's proven, matured, some will mature over time, but I will not give one answer to that. I'll say some cases 100%, some 80, some will 20, 30. It's still maturing. So that's the way it is.
And I almost want to, while I guess even me, I'm a bit on the fence if you ask my team whether or not I'm up or down or agree and disagree with AI. But I think it's important to understand language. It's not perfect. And I think it's very different if I go to a person and the doctor and they give me their recommendation, their interpretation. But I think we also think that AI means it should be a perfect solution, and forgetting that AI is still coded by imperfect people that have parts of information, and it still needs to be validated by a person. So you can't usurp having people integrated throughout this system, from designing it to implementing it. And so with that same thought, I think sometimes because a computer spits it out, it has to be correct. But it's still someone's thoughts that are just leveled up. And so I think there also needs to be a bit of grace when it comes to the capacity for AI, and recognizing that it's still a human design, and that the same way that we would extend that to individuals where we say it's interpretation, AI is just another level of interpretation of data. And so I think that that's something that we really should be thinking about as well.
So I'm going to pick on two more questions that we've had. So part of designing technology that works for and supports humanity is understanding more about the intersection between humans and technology, and what is sustainable in a day, week, or month. Is there any research to leverage on this topic?
I think that's interesting. I can't actually point to any research, but what is sustainable? This changes the working pattern of clinicians, and it changes the job of clinicians, and it changes the role of the patient. So fundamentally, this does change how health systems work. And there is some evidence out there that it adds efficiency to healthcare systems. Very interestingly, there's some research not completed yet that I'm aware of that's being done in Europe that shows as you get much better data and can build automation on it, you increase equity in health systems and you increase efficiency. And the interesting thing for me is actually how we increase equity using AI as opposed to the built-in inequity now. I think that's one of the questions we should be, sort of asking when we, put an AI proposal together. But overall, I don't think we've got any hard and fast evidence at the moment about what this means, in hours, days, or weeks. But really, fundamentally, you have to see that systemically as a systemic change to enable a health system with AI.
I think that's, building on that, it's interesting the flow through a healthcare system. So there's information that goes through the healthcare system that isn't connected. And if you can look at the flows that go through a healthcare system and you can then connect them, so you have the digital front door where people are coming and they are presenting with issues, that's the first time they are accessing that healthcare system. If you can see in real time how that changes and how that is impacted by other things that are happening within that society or within that healthcare system or within that wider system, then you can be more effective later down the line at responding to that. And therefore, you can then use your resources in much more precision ways. We have a lot of blunt tools in healthcare systems right the way across from community care to primary care to secondary care. And we think, well, in the main, that does good. But we do not then actually flow that back to the individual, back to the community, and then into the system. And I think if you connected up the information flow and the data connectivity throughout a healthcare system, using the tools that AI can deliver, then you have much more precision tooling and therefore much more effective use of resources that we know are scarce to delivering against the presenting issues that we have.
I can share just tiny anecdotal evidence from the clinic that I work. We also introduced a very simple, tiny tool to make a summary of the case, medical case record data, which is then needed for sending the summary report to the National Repository. And we ended up with a solution that I think it was a month of work and careful planning. It now costs 30 cents per summary. It is low risk in terms of eventually still the doctor will see the summary for themselves, but it just saves now 5 minutes of each of those cases. And then if if you calculate and multiply that with 1,000 cases, you end up with 50% a full-time equivalent, which in Estonia roughly would cost you 30,000 per year. Or 2,500 euros per month. So we spend 30 euros per month, and we gained 2,500 euros per month. So that when I said that the gains are there on the administrative side, then you can start fairly quickly and with, at least in my mind, manageable risks.
And I guess I have got one practical example, actually, with kidney disease and kidney pathway. So AI-enabled detection of people that were likely to tip into the next stage of kidney disease. And with that pathway, we managed to delay between 9 and 11 months people actually getting to dialysis. So, you know, those things were finding very early signals of kidney disease that couldn't be put together in terms of the doctor just seeing the record.
So I will give an example which everyone can relate to. In COVID time, we delivered the vaccine in 11 months, which typically was a 15-year process. It leveraged technology, it leveraged AI. It's one of the best use cases of saving hundreds of millions of lives, getting a vaccine out. I think there couldn't be a better use case to showcase what technology and AI can do. Even repurposed drugs that were used during COVID were thanks to AI.
Great. So last sort of question before we conclude the panel, and I'm going to combine it with another thing. So the question is, are there ethical rules and standards used in scientific research that could be applied to generative AI models and peer-reviewed like science is? And I'm going to link that with the consumer AI. So the big tech companies, because there's a couple of questions about the big tech companies who are generating data from consumer use. So whether it's Apple Watches, whether it's a Garmin Fitbit, or whatever it may be. So any thoughts on that?
I can just say, if you're saying ethics, we don't have to define it.
Sorry, what was that?
If you're using the word ethics, we don't have to define it. It's very clearly defined what's ethical, what's not ethical. You know, if you just apply it. But if you put profits, denominate it, it is done.
I think that, and certainly, Rachel, you can vouch for that or speak more about it, making data, ethically collected data available for research and finding new insights out of that. I think this is something that should be pursued here. So if you say that Garmin or whoever is, I don't want to blame anyone, any specific, Apple or whatever, I do think that this data in certain way must be made available to the others, so that we can learn but also understand how this data, if used by AI for some sort of profiling, might affect the decisions for us. I recall statement by a Google chief designer on a design conference 10 years ago, when he said on a stage like this that if we would tell people everything we know about them, we would spook them. So that I think this should be democratized. So people should know about themselves as much as possible. And then, yes, we can make use of that together with them in their decision making.
And I think from the research standpoint, rigor and reproducibility is really important. When it's consumer facing, it might be profit driven or internal review, and the benefits of external peer review cannot be underscored more. And I think that's where it differs. And so when you have others who are vetting your data, are vetting your analysis to make sure that it is fair, that it's rigorous, that it's reproducible, it's very different from internal stakeholders saying it's good enough, or, this will get us to the goal, but you can bounce between that line between profit and ethics a little bit easier if you do not have that those external accountability checkers that we have in, let's say, academic research or.
So we've got a couple of minutes. So does anyone have a question or before? Yeah. So we've got the mics. So please say your name, where you're from, and short question, please.
Yeah, thank you so much. I'm an AI scientist from Bangladesh. So I work on AI for healthcare. Just adding with the panelists saying, how we train our doctors. they go to the medical school, they do the residency, and still there is a suspect they can make an error. And that's why we have a regulatory to ensure that they are reducing the error or minimizing the errors. I think we need to consider AI is like that. When it comes to AI, we always suspected that AI will be very bad or something like that. I think if we can put AI as like we training a physicians in the medical school and then residency, and we need to have an AI regulatory systems to ensure that AI is doing right and minimizing the risk. So in that case, AI doctor and human doctor work together, that will make huge impact in the society, and we can reach out to every person in the world, better healthcare with an affordable cost and quality. What do you think? Thank you.
Yes, I've always said that it's like a junior doctor or nurse, a foundation year 1 doctor or nurse, it is there to do a single task and it will be supervised by the senior doctors. So in my view, really this, I like the analogy. I think completely the same way that you do. And to a degree, humans have to be trained about AI, and AI have to go through them, a contextual set of training, especially when we get to things like large language models. It needs to have been through med or nursing school.
When humans refuse to learn, machines start learning. And when you look at the MRCGP exam data, I think the chatbots do better than humans. I mean, they learn. I still believe, a doctor with age 70 saying I have 40 years experience, AI tool with 30 million cases would be much more accurate. I have no doubt on that.
Okay, so last question.
Can you hear me?
Yeah.
Working great. Yeah, hi. My name is Ricardo Leite. I'm the CEO of Health AI, the global agency for responsible AI in health. Based in Geneva, we work as an implementing partner with several governments around the world and with WHO, building regulatory capacity regarding the application of artificial intelligence in health systems. And I think this is a very important discussion. I'm not going to go through the chatbots issue, but the reports looking at that actually show the robots show more empathy, actually, than humans. As a physician myself, that tells a lot about the way we're training doctors to be machines and not to be humans. But that's a whole different conversation that is worth a panel of its own. I want to talk about data. And what you mentioned is extremely important. And we focus on responsible AI. Of course, fairness, inclusivity, explainability, all of these issues are critical to what we do, but also human rights. And there's an issue when you talk about data, it's the way data is being collected right now, particularly in low and middle income countries, by a lot of companies that are not necessarily complying with human rights and dignity in the workplace. And that's one issue that we all need to be sensitive about. Responsible AI should include sustainability. And right now, 3 to 10% of all energy consumption of the world is being used for the maintenance of data centers and within the context of data collection and curation and analytics. And so these issues, I believe, should be included in this discussion. And I'd love to hear your comments. But there's a particular question I want to ask, because we're particularly concerned in the field of health of building a global early warning system with WHO towards post-market surveillance of technology. Because a lot of people are focusing about the future potential. We want to benefit from the potential today. And how would you see in the future that post-market surveillance can be done in real time or as real time as possible to make sure that not only approving technology to go into the market, but to make sure that that technology maintains the specificity and sensitivity that was demonstrated at the moment it was assessed? It's a huge discussion, but I'd love to hear your thoughts on it. Thanks.
Can I take that one first? So, I'd identified that running a number of different AIs in, a large healthcare organization. So we created a life cycle management regime to oversight AI, things that we would monitor and measure real time, audit, clinical risk, output, retraining. Actually, one of my former students has now taken that and started a company which has got an oversight platform for AI in healthcare that gives you almost cockpit view of how all of the AI is performing, and is talking to our regulator in the UK about that. So my view is that you need to be able to, just like a nurse or a doctor, be able to see its performance, be able to praise it, audit it, and all of those things in real time. Because when we are at full flight with AI, we are going to have so many in our fleet that we are going to have to exception manage as opposed to doing this by rote. And there will not be enough manual, sort of experts to actually do that. That's not efficient. So lifecycle management platform and oversight. And if you want me to talk about my student's company later, he's doing amazing things and is working with the UK regulator.
Agree. You need to apply the same principles to the regulation as we are to how AI applies to provision. It has to be dynamic. It's got to be regular. You think about our regulation principles in sort of in the main. It's like an annual appraisal. I mean, what can shift in that time? And so we have to completely change the principles of how regulation is done, so that it keeps up and so that we are taking advantage of it, but also protecting ourselves at the same time.
Great intervention.
Can I, let me just
Oh, yeah.
ask, just 30 seconds. How many people in the audience represent lower income countries? Can you raise your hands? You can just see, you know, the kind of representation we have on discussion on tables. So Ricardo and you are doing a lot of good work in this field. My challenge is when big tech has a seat on the table, but not LICs. I think when then we are just flipping the model towards business and not about the real use case that we need today. Thank you.
Okay, so with that, I'm going to draw it to a conclusion. So please put your hands together for the panel. Thank you very much. Thank you. So our second keynote speaker has arrived. So if I can call Hani Askander, who is the head of digital services at ITU, to come up and speak.
Okay, good afternoon, everyone. My real apologies. I didn't notice that it's 245 Park Avenue South. I'm learning. AI, we need AI for that indeed. Okay, so my name is Hani Askander. I'm the head of the Digital Service Division at the ITU, International Telecommunication Union. I'm based in Geneva. Most likely you know that ITU is a big advocate for AI. We have a major big event each year, which is called AI for Good, and even webinars across the year. We almost in contact with everyone who is doing something on AI. And giving that, countries come sometime to us and say, can you give me advice on should I use AI and how and why, etc. So this put us in a kind of a critical situation. And I would like maybe to share with you how we are trying to formulate our position vis-a-vis the actual use of AI on the ground. First question is to say, well, it depends on what you need to do. What is your objective? Why I'm saying this? Because we have seen past waves and hypes about technology. Do you remember what was one of the previous ones? You know, maybe a few years back, 5, 7, 8 years back, it was about mobile health, right? Do you remember that? It was so exciting. And people thought it is the first time in history that all human beings have something where you can reach out to them. And there was conferences like exactly this one talking about mobile health, mobile health, mobile health, mobile health. It's going to change the health systems. It's going to empower patients. After so many years, what do you think? So here is a question for all of us, including us as international agencies. And I'm asking you this question now. I will hope for some volunteers. Do innovation lead to digital transformation? Yes. Who say more? Who say yes? Raise your hand. If you say yes, raise your hand. Do innovation lead to digital transformation? Okay, who says no? Ah, it's equal. We need to take a decision. Okay, someone from those no camp, can you say why do you think that digital transformation doesn't necessarily lead to digital transformation? Yes, please. Yes.
Okay. I think innovation is a natural process
Yes.
that is happening hundreds of years. According to the time, it changes its behavior.
Yes.
So now the era of digital transformation is, we can call it innovation. But as you said, that when mobile health, that is another things. So I think innovation is a continuous process. Every day we're changing our, facing challenges and trying to bring ideas to solve the problems.
Yes.
And that creates the innovation. And now the technology is like a fourth industrial revolution. Maybe after some years, you'll see fifth industrial revolutions, and there's a better transformation will happen.
Yeah.
You will say like fifth generation transformation or like
Okay.
fifth generation
Great.
transformation.
Thank you very much. Thank you. Okay, so let me maybe explain. After the mobile health hype, people were quite frustrated because they didn't see the real impact on the health system. Nothing really changed drastically. And actually, it was even opposite because there was a lot of duplication and a lot of replication, and the same application is repeated 4 or 5 times. It didn't lead to a change in the health sector. The big difference between innovation and digital transformation, in my opinion, in innovation, you are focusing on one problem to solve, which is great. In digital transformation, you are thinking for the whole overall system. How you solve the bottlenecks in the system so that information can flow. If you think of all the use cases where you can describe a digital transformation happening from the citizen perspective or from the healthcare perspective or health manager, is about what? Remote care. This is a big issue in low and middle income countries. Access to care, virtual care, self-care, continuity of care, telemedicine, etc., all depends on one key thing: helping information to flow within the health sector. This is the key enabler for what you can call digital transformation. So the question for me is to say, is this innovation helping you to reach a system-level digital transformation, or it's helping you to solve one particular question, one particular problem? One particular problem is great, but it's not enough. So the way we approach it and say, there is an elephant in the room. We've been talking in digital health since many years and investing in innovation without seeing a real digital health transformation because we didn't think at the system level. So there are things that needs to be done to address this issue of enabling information flow within the health system. And those kind of new hypes and new innovations should not distract your attention and your investments from really tackling the hardcore problem that can really enable even AI. I think many people in the previous panel mentioned that, there is still data. We don't have yet the data. I mean, many countries don't have even basic registries. They don't even struggling to digitize basic procedures. So if your innovation is not going to distract you from the real investments that needs to happen to enable digital transformation, then it's fine. So that's criteria number 1. Criteria number 2 is that you need to do it in a way that is evidence-based. I think from what we have seen so far, and I think it has been repeated in the panel, there are maybe 2 use cases that proven to be more or less ready to go around image processing and image recognition diagnosis, like, for example, pre-screening of or early screening of cervical cancer or retinopathy. There are some, I think it's solid, those use cases is solid, but it's very expensive. Need to think of scale. A retinopathy costs $7,000. Can you think of going in Senegal? We had a project in Senegal and have a retinopathy in all the health centers? It's impossible. So is this ready to scale? My assessment, no, not yet. Maybe when we have low-cost cameras on mobile phone, yes. The other use case is around the chatbot. But in the chatbot, I think there are still a lot of things that are not ready. Languages. There are still many local languages that are not yet good enough, and there is a lot to be done. Accuracy needs to be improved. Cost. Which LLM are you going to use? Are you going to use OpenAI? No way, you cannot scale it. It's too costly. Then you need to use open source. Then you need to have the local resources. Again, is this ready? So what should be our advice as international agencies to countries like that? Say, listen, don't lose focus. There is an elephant in the room. If we don't solve it, we will not be able to leverage truly the AI and any future innovations that will come. You need to enable information flow. You need to build your core data sets. This is the priority. What was unfortunate that many of the countries were very focused on innovation, and they thought, I think wrongly, that they were doing digital transformation. I think those two things are different. The approaches are different. Here you need to think of system, architecture, interoperability. It's slightly different. Second, have evidence that it works and it is feasible. And then I think our suggestion is to say, don't lose focus. You can pilot and trial to build capacities, but you need to continue build learning. And in that sense, I think ITU and WHO has made some very good initiatives to really to help countries do a very, how can I say, objective benchmarking for AI solutions and diagnostic tools. There was a focus group that focused on a number of use cases. And now we have launched with WHO and WIPO an initiative on AI. It really try to think what kind of standards are needed, et cetera. So I think there is a lot of learning. So our advice to countries, put yourself in the learning, pilot, so build on capacities. But I think that this is not yet fully ready, at least for the countries where low middle income countries. Build your capacity, pilot, but don't lose focus on what are the priorities. If you don't put this digital infrastructure in place, you are going to miss the train, for sure. And unfortunately, this is what's still happening so far, and the innovation didn't really lead to a real digital transformation. So I'll stop here, and apologies, I maybe took a little bit more time. Thank you.
So I'm going to move us quickly along. So if I can ask the last panel to come up onto the stage, take their seats, please. So Henrietta, Eric, Tobias, we're one down, so. Wherever you want to sit, doesn't matter. Okay, so this panel is talking about AI in health system management, policymaking, international collaboration, and the future of AI in health, and how could digital healthcare help the World Bank to deliver affordable health services to 1.5 billion people by 2030. So all that's, we don't have to cover everything, but off we go. So just like the last panel, we're going to do the same thing. Each person's going to speak for 2 minutes and do some positioning, and we'll go from there. So Eric, will you start us, please?
Sure. First of all, thanks for having me. As we sometimes like to say in the South, everybody's not busy, which means everybody is super busy with, nobody's not busy, that's the phrase. So thanks for having me, and thanks for attending today as well. A little bit about me, I studied accounting at University of Florida, moved to Nashville about 40 years ago, and being in Nashville was thrust into the healthcare industry. A little bit about Nashville as an ecosystem. You might know us for music and hot chicken, but we've actually got about 500 healthcare companies there, national operations, provider-oriented, segmented community, 3 academic medical centers, and about 15 public companies as well. The area that I've always been interested in is this intersection of innovation and deployment and scalability. And that's what I believe is you find in the expertise in the community in which I live in today. So after 40 years in the industry and chairing an accelerator program, I'm currently an ambassador of an organization called Health, HLTH, international conferences in Las Vegas, as well as Nashville and Amsterdam. And recently, the formation of Health Community, which is an online and virtual set of resources and community and ecosystem to really drive the industry forward in a number of ways. And then finally, I'll say with respect to AI, you know, it's not even been 24 months since the announcement of OpenAI's ChatGPT, which created a significant amount of buzz in the industry. And while predictive modeling and computer vision and NLP and certain technologies have been around for many, many years and a couple of decades, it's really put a spotlight on how we can leverage this technology now to solve some of the macro challenges that exist in the industry. And I found that those challenges generally are similar in developed countries. So aging population, rising cost of care, and critical workforce shortages. And if we can harness the best of that technology, deploy that at scale, I know that we can make a real difference in the industry and the patients that we're caring for.
Good afternoon. I hope you can hear me. So I've made a few notes because this morning I got a little bit excited about the fantastic sessions that we had on women's health. So my name is Henrietta. I work for the European Commission. The European Commission is the executive arm of the European Union. We fund research and innovation, but we're also a regulator. And we have spent around 2.5 billion US dollars on AI research and innovation, and specifically around 200 million euros on AI and health applications. And I represent a massive research innovation fund, which is called Horizon Europe, and where we have a budget of around 100 billion. And this budget is open for research cooperation with anyone, everywhere globally. So anyone around the world can partner with scientists and companies in Europe on R&I and also on health and AI. I'm a practical person, so I would like to give you two examples of what we invested in as the EU. Firstly, we invested in a project called Decipher. Decipher is a lab-on-a-chip application that we're doing together and in laboratories and clinical settings in the DRC, Guinea and Médecins Sans Frontières. And there we use AI to really optimize performance on lab-on-a-chip. So that is a real-life application for Lassie and Ebola viruses. The second, and I know Marleen Timmermans is maybe in the audience, but I saw her. We're doing an exciting project with the University of Barcelona and the Aga Khan clinic in Nairobi about using AI for ultrasound in low-income and rural settings. So how can you optimize and how can you combine the big data sets that we have in the West with the incomplete data sets that we have in rural settings in Africa? So as you said, there are a number of case studies. We do this for infectious diseases, for non-communicable diseases, and also for health and maternal health. But what I'm interested in as a funding agency, as a regulator, is indeed questions about what and how is AI applied? Who and where are we going to do this, and what is going to happen with that data? And as you know, the European Union has put together a package of 3 big regulatory items, which are around GDPR, the AI Act, and also the European Health Data Space. And all these 3 packages have at the core the fundamental human rights of each and every one of us. So the fundamental human rights is most important, is what is guiding the use of any technology and a new product on the EU market. So this is a little bit what we are doing. I know that the folks of EDCTP, Marleen Timmermans, Evan is around here. We are open for cooperation, and we would like to hear from you. Thank you very much.
Tobias. Hello, everyone, and great to be here with you. I'm Tobias. I'm originally a biochemist and immunologist, and work on digital transformation of health systems in McKinsey, and had the pleasure of growing the Health Tech Network over the past 10 years, which is now a community of 1,900 health tech CEOs and founders, 400 investors, and 400 healthcare organizations, including the EIC in Europe. I think in this AI discussion that we are having, I would invite us to sort of go back to a bit the first principles in terms of healthcare and ask, does AI help with prevention and keeping our populations healthy? Does AI help with chronic disease management, given that in Europe many countries have 40 to 50%, and in the US even more, percent of the population having one or several chronic diseases. Does AI help with acute care? Does AI help with pandemic preparedness? And considering that the FDA has been regulating and approving AI solutions since 1995, of which we currently have 950 in the list that they updated last month, I would say it's pretty disappointing what the impact is and what the scale of AI is. To be the person who pretty much is a bit more negative on these panels. But if we look at the list of 950 approved AI medical devices that the FDA has looked at over the last year, 76% are in radiology, right? 76% in radiology, and it's been pretty much 30 years, right? So, you know, that doesn't help that much with prevention. That doesn't help that much with chronic disease management. Yes, it helps with a niche of acute care, and it doesn't help with pandemic preparedness. Of course, AI would help with it if we would do disease forecasting in the same way as we are doing weather forecasting, but currently we are not doing it yet at scale. But so I think, therefore, I would offer the thought of, especially in this public health, global health community, that we also think about how would we like to get to digitally enabled health systems for the 2030, 2040 perspective, right? And then think through how can we actually redesign our health systems that they are amazing at prevention, amazing at chronic disease management, better at acute care and pandemic preparedness. And therefore, I very much, like the notion of rather talking about digital transformation of healthcare instead of only AI, right? And if you haven't heard about it, right, Alain Labrique and the Global Initiative for Digital Health at the WHO are trying to go in that direction, right, where we are then thinking about, right, how are we redesigning our health systems, or as Hani called it, how do we do the digital transformation of our health systems so that we adapt our governance, we adapt our financing, we adapt our resource allocation, and we adapt our incentives in the health systems, right? So that we improve what we want to improve, right? And then some things might be just digital tools without AI, and other things might be digital tools with AI, and a lot of things will be in-person plus digital plus AI, right? But in that sense, I would advocate, as also Alain Labrique likes to call it, that we don't just focus on building fancy Formula One cars, but we actually focus on public transport, building the streets, and then also the cars.
So I'm going to tell you a little bit about Tobias for a second. So he's been playing with all sorts of digital health tools on himself as part of an initiative inside McKinsey's to actually work out how should they make digital health tools available to their employees. So he's a bit of an experimenter, okay? And then the other thing is that he is, I think, I'm not sure whether it's an ambassador is the right word, for a charity called FH Europe, which is familial hypercholesterolemia, which is genetic high cholesterol. And today is World FH Day. So a shout out to the charity that he does some work for. And as ECH Alliance, it's one of our organizations that we support. So that's what I'm doing. Right, now back to the discussion. So Henriette, I'd like to talk a little bit about the AI Act for a second, and actually the EHDS as well. So at the moment, EHDS is still not final version published of what the regulation is, but more importantly, the implementation. There is a huge amount of work to be done by the European Commission and then by member states. Is it true, do you think, to say that we're a few years away from knowing what that will, European health data space will actually look like and how it will operate in practice? Is that a fair summary?
Yeah, absolutely. Health and health provision in the EU is a competence, is decided on a national and sometimes even on a regional level in Europe. Yeah? So you have regions in Germany, regions in Belgium that are responsible for healthcare, for a lot of the healthcare provisions, and especially if you're going to go to social care. So if you multiply 27 times a number of regions, which also have a very distinct idea of what healthcare should look like. And many people joke that in Belgium you have the beer-wine border, yeah? So above Brussels, people like to drink beer, and below Brussels, people like to drink wine. There are many cultural kind of healthcare ideas about when do I ask for an X-ray? And you see that in some regions, this is really much more, you can only be treated well if you have received an X-ray or antibiotics prescription. So if you want to put all that data in a health data space and keeping the idea that it's really about privacy, fundamental rights, then we're talking about 5 or 10 years. What we really have tried to build in is that there is a very good framework for the secondary use of health data space, and secondary use of health data means that the research innovation community can use that data and have a lot of access and also very standardized access to that data. So I hope that...
So it's going to be a number of years as we learn by doing, almost, in the context of adopting AI and examining the use cases. So it's going to be some time. This is not solvable or all solvable today. As the last panel we're talking about, there are a number of complexities, and we're going to have to learn as I go, as I said, by doing. So I'm just going
to... learning by doing is a very good time spent, a very wise money spent.
Yes. So I'm just wondering if anyone's got any questions out there, or if you start thinking about them, because we've got a couple of minutes. So let me know. So Tobias, what do we think, looking at those use cases, what if you were looking ahead and thinking, actually, what could AI do as opposed to what it's been doing in radiology as the use? Where do you think you're going to see some of the really exciting use cases that health systems might be able to use?
I think AI and digital tools in general, right? As Bladen said, I'm a bit of a biohacker and I use all sorts of tools, right? So even if from a system impact, I was striking a negative or disappointed tone, I personally am very excited about what digital tools and what AI in total can do with health and well-being for us as citizens or as our populations. So the three main reasons why I'm excited about digital tools and AI in healthcare is that it can help citizens with sustainable behavior change, right? And often when I look at my children and how they use social media, I see sustainable behavior change, but probably not for the better. But I think digital tools can actually help us citizens with sustainable behavior change in terms of better sleep, better nutrition, better fitness, nudging us towards being a little bit better and a little bit more consistent in our behavior. And that's then both positive in terms of prevention as well as in terms of chronic disease management. Right, and it's usually not about knowledge, it's more about getting people to do that, right? Being German, everyone in Germany loves their beer and everyone knows better how their car works than their body works, right? But actually getting them towards a way how to improve sleep, nutrition, fitness, stress management, and ideally doing it in a fun way. I think digital tools can play a great role there. I think the other part is easy accessibility and equitable access, that we have a really easy access layer for healthcare. And then the third part is freeing up times of doctors and nurses, right? Doing less documentation and spending more time with the patient. So I think that would be the use cases. And if we spell that out a bit in the prevention space, right? That's then like, checking how my blood, I'm a lipoprotein A and an LDL cholesterol patient, right? So I'm pretty sure I'll die of a heart attack or a stroke at some point in the coming decades, right? But for me, it's then interesting to know what what is my, well, now I can be really relaxed because I know it, right? So in that sense, how can I actually then, improve my blood pressure, my lipids in an informed way to actually then, intercept that risk that is there, right? And I think in that respect, that can be a lot of what AI then can do in terms of health coaching and disease interception, so that we know that we might have a diabetes or heart attack risk in 5, 10, 15 years down the line, but we are now moving our behavior to the better today, that we avoid that.
I was just going to maybe echo one of those and then add one other. Certainly in the area of assisting clinicians, what we're seeing widespread in the U.S. is the use of ambient clinical documentation is really well accepted by a number of studies, a number of physicians that are leveraging that technology and then summarizing valuable data that is contained in a health record, whether that's structured or unstructured data has been proven valuable in that regard as well. So I'd echo on those two comments.
So I'm just going to move us on to the last topic, which is really, already each of you have said something about innovation. So in Henry's, you were talking about the opportunities that you fund, and not just in Europe, but anywhere around AI. I know Nashville does a lot of innovation, and Tobias and the Health Tech Network is all about innovation. And given this is the United Nations and it's the Science Summit, I'm just interested in what do you think are the opportunities for cross-border or true global collaboration around a subject that none of us want, or no one country can solve, no one continent can solve? How do you think, or what sort of call to action might you have around that international collaboration?
Yeah, so I see at least two big opportunities. One, we need to speed up drug development massively. And I see there AI giving a huge opportunity in there. Also, as a very positive effect that we model more and that we maybe use fewer animals, lab animals. It's very sensitive. But I think most important is something around pandemic preparedness and going further, that we combine AI with a kind of what we call ever-warm clinical trials infrastructure. And this is why we fund from the European Union a lot of skills development, a lot of infrastructure. We do a lot with the African Union. We do a lot with the African CDC to get this ever-warm clinical studies ready. And I think there AI gives a huge, huge opportunity.
Anyone else? I might just weigh in a little bit. The volume of clinical knowledge in medical research, it's widely been studied as was probably projected to double in 50 years back in the 1950s, and then the early part of this century maybe to 7 years, and 2010 maybe to 3.5 years. And we're living in a day right now where what we know about medicine will probably double in less than 73 days as of the latest projection of that. That activity is only going to increase with large data sets, better genomic sequencing, more consumer social determinant data, the digitization of EHRs, which has been on a 15-year journey in the United States. And I think the opportunity is, how do we really leverage AI and some of these massive data sets to be able to inform, train, educate, and put into use with the clinicians of both today and tomorrow? And I view that as a significant challenge, but a grand opportunity.
I think there could be two areas, especially in this cross-country setting that we are at, right? I think one is, given that we also had Rajendra Gupta on the previous panel, India has done a pretty impressive job between 2009 and now in terms of digital public infrastructure for healthcare. And, and if we think about digitally enabled health systems for the future, it will often be, right, also as you said, Ein, often be around national electronic patient records, about digital identifiers, about wallet payment solutions, maybe in low middle income countries. And many countries will want to do that as digital public infrastructure. And I think there can be a lot of learning and collaboration between countries. And if we do that well, or if we would do that well, then it could also actually be as a cross-country healthcare market, right, where then digital identifiers or wallet and payment insurance solutions could actually be done also across countries. And I think the other part would be around governance, financing, right, creating budgets or creating mechanisms that maybe might not be too similar as how we do the energy transition, where we create new budgets for wind and solar and manage down the old budgets for the other fossil fuels.
That's a wrap from us. So if you could put your hands together to thank the panel. Thank you very much. And I'm just going to close today. So I thought we had a fantastic session on women's health, and I am really grateful to Irene and to the Society for Women's Health Research for being our partner for the day. I like to think that we work very hard at facilitating collaboration across borders with organizations, with people. I hope that there'll be many initiatives that come out of this day where we have made those connections. So please, I really liked Irene's thing today earlier when she said, you know, what you've got to come away with is one action, 2 organizations that you can help, and 3 people that you're going to contact in the next couple of weeks and make some connections. So thank you all very much for coming. Very grateful, and I'm very grateful for all the speakers. Thank you.